Welcome to Shaping Healthcare, a podcast by CitiusTech. I'm your host, Laurel Rockle. Welcome to today's episode where we dive into the evolving world of CMS regulations and their impact on healthcare providers, healthcare delivery, and compliance. Joining us today is Sheetal Sawardekar, AVP at CitiusTech Healthcare Consulting, focused on provider market. With a deep passion for medical devices and healthcare technologies, and now a strong focus on healthcare IT for more than a decade, Sheetal brings a unique perspective on how CMS regulations are shaping the future of care delivery and its impact on providers. CMS regulations are designed to improve care quality, transparency, and accountability. But for many healthcare organizations, they also introduce new challenges, especially around compliance, reporting, and adapting to digital systems. In today's episode, we will unpack what's changing, who's impacted, and how organizations are navigating this complex landscape. Welcome to the show, Sheetal. Thanks for being here.
Thank you, Laurel, for the very warm introduction, and it's a pleasure to be on your podcast.
It's a pleasure to have you. We certainly have a lot of things to talk about. And so before we dive into the regulations, could you briefly describe the scope of the healthcare providers that are affected by CMS policies?
Right. For this, we need to understand who healthcare providers are. And they are a broad spectrum of resources that deliver health services to the patients. So that what we are going to consider are the facilities, the physicians, and the clinicians who are going to help the physicians. These are all the patient interacting roles, which are all covered under one umbrella of what we call as healthcare providers.
Thank you for defining that scope, because yes, there can be a lot of different moving parts to this. So with that in mind, then, what are the key current CMS regulations that have been shaping healthcare today?
So to understand the current CMS regulations, we have to take you a step back and explain you the evolution of care delivery models so that you'll appreciate the journey and will understand the model that we have currently. So for the longest time, the healthcare delivery worked in a fee-for-service model, meaning the patient pays every time they avail a service. And that seems very logical, right? But the problem here is that we are addressing the symptoms, the symptoms that the patient is currently experiencing, and we are working in a very reactive mode. And that is the fee-for-service model. And if we zoom out and look at overall healthcare landscape, so the entire healthcare industry is working in the reactive mode, which should not be. Instead, it should be more proactive. It should be more preventive care. So in order to march from fee-for-service to a more value-based care is what the name is. So to move from this journey from fee-for-service to fee-for-value model, so that is what we are looking at currently. Okay, and it is all covered under the umbrella of value-based care. And then there are different, so I said that these are all different payment models. So fee-for-service is a payment model. And then the fee-for-value is another payment model. And there are different payment models that are devised by CMS's Innovation Center. CMS is our Center of Medicare and Medicaid Services. And all of these are covered under the umbrella of value-based care. So to answer your prime question, right, which is the healthcare trend, that is regulation that is catching up, it has to be the value-based care when it comes to the healthcare providers.
That's a really excellent point to make, is pointing out the reactive versus proactive and how what an incredible change that is and how that changes the pay models. And also, I mean, some would argue that that's really healthcare, right? Is being able to take care of the whole person, be proactive, for these providers. So what are some of these major regulatory bodies behind value-based care, and how are they influencing healthcare policy and payment programs then?
Okay. One thing I need to highlight on value-based care is that we are looking at the overall patient's well-being and not just one symptom they are currently experiencing. Okay. Now coming to the next question, right? What are the major regulatory bodies? And that's a good question. So we have to talk about regulatory body. Let me take you from the top down approach. So on the top, there is always Department of Health and Human Services, which we'll refer to as HHS. And their main agenda is to provide high quality, equitable and affordable healthcare. And then there are different bodies under it, like you have heard of CDC during COVID times, there is FDA, and then there is CMS as well. And CMS is what we are going to, what I'm going to talk about. So CMS is Center of Medicare and Medicaid Services. Now, this is all the entire digital world, right? So we have CMS and the HHS is publishing all their resources, all the healthcare IT resources on an official website. And that website is managed by Office of National Coordinator of Health Information Technology, which is healthit.gov. And then we spoke about CMS, which focuses on, it says Center of Medicare and Medicare Services, but it is the primary architect of the value-based care delivery models. These are all the different payment models like fee for service. There are other models that they devise. And their focus is a lot on quality measurement and alternative payment models to pay our physicians. And then there are different consortiums formed by payers, which is AHIP, then there is AMA, and these are all a multi-stakeholder collaboration platforms uniting the public and the private sectors coming together. So, yeah, so this everything flows down from HHS to CMS, what we are going to focus on.
Yeah, there's quite a few regulatory bodies all working together and all with their specific focus, as you said, like they're running through, from top down, running through each other and different regulations passed and acts. So what are actually some of those acts and regulations that have helped shape CMS's policies?
I like how your questions are going through, and it is helping me focus to my area of interest. Mm-hmm. And as I'm thinking about the acts and regulations, so first and foremost should be the Affordable Care Act, which came in 2010, and it was signed by President Obama. And it was the first time when the marketplace was designed. It is literally a shopping center for health insurance. And that's not the only thing that it did. It laid the foundation stone. And one thing that you might have noticed that insurance plans now cover annual preventive healthcare with no copay or no deductible. Now that was introduced as part of that particular act, and there are many other clauses, and that has been the foundation. Okay. Now to get to the digital world, we need two things. One is the infrastructure, which should be credible and standard, and second should be the process of providing quality of care. So for the, if I have to talk about the infrastructure, it is the High-Tech Act, which provides certified EHR technologies. That is, EHR is the application where the physician uses it while the physician interacts with the patient. There is an application where he addresses and types everything. So that is the EHR. So that should be a certified one, which should be capable of ingesting standard data and sending the standard data out. And then we talked about process of quality of care, and that is where the regulation comes in, and I should call MACRA there. And under MACRA, there are many other, it is like a payment model system, but one very important is merit-based incentive payment system for the physicians. So physicians are paid based on their scores, their merit. And they have a short name, we call it MIPS. And that is one very important regulation we need to talk about. And then very recently, they published 21st Century Act. It's not very recent, but it gathered a lot of momentum very recently. It was published in 2016. So what it does is that it penalizes the healthcare systems, like the facilities, the physicians. So whoever are causing information block, they are interfering with the exchange and access of healthcare information across. Okay, they will be penalized. So they are trying to make it a digital world where everything flows in seamlessly. So, and then we should also talk about FHIR. So there is always a data exchange format. So when the data from point A to point B should always transfer in a standard format. So we had HL7 DICOM standards earlier, but now it's FHIR. And all these regulations talk about FHIR, which is FHIR. They pronounce it at FHIR, but it's actually FHIR, and that is one particular main standard that we need to emphasize.
Yeah, no, thank you. Yeah, and that's, you're right. There's all these regulatory bodies, there's these different acts and regulations, and yes, we're narrowing things down, and especially as it's moved into a digital world, and what that landscape looks like. And of all these acts and regulations, if you had to highlight one that's having a major impact right now, what would that be, and what makes that so significant?
Yep. I have always been passionate about the physicians. Okay. And the one act that kind of impacts the physicians has to be the merit-based incentive payment program. It is the acronym is MIPS that we are going to talk about, right? So this MIPS is very important for multiple perspectives. So first of all, it is a payment system. It is replacing the fee for service payments that the providers receive with a merit-based incentive payments. Okay. So first and foremost, it is a federal mandate that is brought in. So they have to do it. If they don't, they get negatively penalized. Second thing is that the physicians are either getting incentives based on their scores. We call it as MIPS scores. Or if the MIPS scores are lower, they can also get penalized. So it directly impacts their bottom lines. So that's why it's important. And the third and very important factor is that this MIPS score is like a credit score. It travels with the physician everywhere they work, everywhere they want to avail their services. The score comes into consideration. And not only that, the score is also publicly available for you and me. We can go. There's a website called as Care Compare, which is published by CMS, and they publish all the scores for everyone. So it is very important for them to follow this, and that's why I think one program that if I would choose that is significant for the healthcare providers, it should be the MIPS. Now, the MIPS composite score is what I was talking about. MIPS score. It's very difficult for CMS to come up with something that measures how good a physician is, right? So because there are different aspects to it. What is the cost of care? Okay. What are the processes that the physician himself or herself have undergone, and what are the processes that facilities have undergone? Is the applications that they use, are they certified by ONC? Okay, and are they providing quality of care? No? All of these aspects together combine to form this MIPS score. And what physicians have to do is that they have to provide necessary documentation to prove that they are following these standards. And that's why I think MIPS is the one that we need to focus on when it comes to healthcare providers.
Yeah, that is significant. That's fascinating. It's nice to know that that information is available to the public, and that there is that criteria there to compare the care and be able to see what your the score that your providers have. So thank you. And I would like to touch on something that you were mentioning at the end, and measurement and quality of care. And we often hear about quality of care. That's something we hear all about in this landscape. But how is that actually measured under CMS regulations? How do you measure that?
Yeah, that's the tricky part. It doesn't have a yardstick. We cannot use any other available units to measure the quality of care. But what CMS has done is that they have defined some criteria in place. What they call it as clinical quality measures, CQMs, and we can just refer to as quality measures or measures. Okay? And each quality measure is addressing one specific area that the physicians need to address. Let me give you a very simple example. So there is a patient with diabetes who walks in for some like stomach upset or something like that. Okay. But there is a measure that is defined by CMS which says that if you happen to be visited by a patient who is diabetic, in other than solving whatever is the symptom, you should also do foot examination. Okay. So if foot examination was done on that patient, the physician receives a brownie point. Okay. But the patient should be a qualifying patient, right? So if another patient walks in with the same symptoms but is not diabetic, that patient doesn't qualify for this particular quality measure. Okay. Now, if the physician is now looking at 100 patients, which are all 100 of them are qualifying, and the physician happens to do foot examination on 90 of them, so the physician's performance score is like 90%. Okay? So that means the physician have got a quality score of 90% on that one measure. Okay? So the example that I gave you is just a process measure. There could be outcome measure like blood pressure or HbA1c should be less than 7%. So they have defined certain measures per major diagnosis that we have around, for major specialties, and they have like 100 to 105 measures that are available for physicians to choose from based on their specialty, based on the type of patients that they receive. So they can choose such measures. And with the help of such measures is what CMS can assess if quality of care was provided.
That's really interesting, and that makes sense then in terms of measurements. In looking at maybe what could, in the case of diabetes, what could be a common complication with that, and also adds into what we were talking about earlier about more proactive healthcare, and not just addressing symptoms, but looking at more than just the stomach ache. When someone comes in. So thank you. Who are the key stakeholders who are impacted by these regulations?
It's the physicians. And when we talk about physicians, it is not only core physicians who are NDDOs, it is also some of the clinicians who are combined, and they are they are all called as MIPS eligible clinicians. So it is the physicians and the clinicians who are helping them.
And what are some of the pain points and the challenges, and how does value-based care solve that? Like, why are we focusing on physicians and clinicians then?
Yeah, now that is what I'm passionate about. I really feel for them. My sister is a physician, and I always wanted to become one, but I saw her struggles. I saw the length of study that they do for 10, 12 years. This 10 to 12 years is just equipping them to perform the core job of taking patient care. But at the end, in today's world, that is not enough. They are challenged by ensuring that enough documentation and enough proofs are maintained to prove that they are taking quality care, not just caring the patient, but quality of care, which is measurable. Okay. They need to ensure that the clinical notes are very sufficient enough for the billing center to add the diagnosis code, procedure codes. There is always a component of natural language processing here. It's not only the diagnosis and procedure codes. They have to ensure that the measure specific codes are there. There should be some code which says that foot examination was performed. Okay, and those specific codes should also be there. That documentation should also be there. So although they have physician assistants, CRNAs, LNPs helping the physicians, but at the end, it is their name, the billing provider is their name that comes in, and the MIPS score is assigned to them, and that's why they are really, really challenged. They have the CMS submission burden. It is not just enough to provide quality care and stop. They have to assimilate all the documentation and do a CMS submission for the MIPS. And these submissions, like all the federal mandate programs, they are helping the physicians ramp up to the regulations. And this MIPS has always been an evolving program since 2016, 2017 when it was launched. So to give you an example, the initial qualifying points for getting incentives were just 3 points, and now it is 75 points. And the measures are not same. So every year CMS keeps on revising this measure based on the population health, what is bothering So for example, breast cancer, there's a measure on breast cancer, there's a measure on colorectal cancer screening. So they keep getting this newer and newer measures. So that's why that is their main challenge. And you know what? Out of all the major stakeholders, we know patient is at the center, but the payers, the drug and pharma industry, they have a more financial relationship with the patient. But physicians have both financial as well as what I call it as human relationship with the patients, right? And they are at stake. So there is a lot of burden on the physicians, and physician burn down is a real thing, and there is a lot of burden on the clinicians, and that is why I feel a lot for them. And CMS is also helping them in different ways, and that's why we are focusing on physicians and clinicians to answer your main question.
Wow. Yeah, that's a lot. That's a lot of the providers. And I absolutely understand your passion for this topic and why you feel for them. As this has become stricter and tougher, and there's just more of that challenge on the providers. And
Yeah.
that's really becoming the norm, stricter benchmarks, the digital reporting. How are healthcare providers and organizations adapting to stay compliant and stay on top of this?
Yep. So for so you said stay on top of this. So for staying top of this, here are the things that anyone needs, people need to know, or the physician needs to know. Knowledge of federal programs. There is so much documentation. There are so many publications. But what out of that is applicable to me, and what out of that is really what I need to focus on? Okay. Knowing the documentation requirements. What are there any specialty specific requirements? How about the data plumbing? So even if I do it, will that data flow from point A to point B where all the calculations happen? And if I'm performing as I'm performing today, will I get incentive? Will I get penalty? Are there any special bonuses for being a small practice or helping the rural areas? So so the physicians need to have this knowledge to be on top of the things. And our physicians, all the physicians come from a very clinical background, and this is just a challenge for them. Okay. Good thing is that CMS is helping them in getting on this particular wave. And it's important, value-based care is important. The nation won't survive with fee for service. And they acknowledge that the physicians are at uh, are the central authority who is going to bring this change, right? So they are making it easier for them step by step. And to answer your question, right, how are healthcare providers and organizations adapting to stay compliant? So what CMS is doing is that we spoke about these measures, like foot examination is kind of a measure. Okay. So they have opened different ways in which the data, the documentation that they have captured can be submitted to CMS. We call it as CMS submissions. So they have a web service like a portal where they can just assimilate the information, and they have published a standard format in which data has to be published. They can upload the files. But this is the last year it is sunsetting, and that was only for Medicare patients. Now, physicians are not looking at only Medicare patients, right? They have all payers, right? So then they devised another mechanism where the EHRs, which are the applications at the point of care where the physician meets and communicates with the patient. So that particular application itself can capture and then send, but it is not as easy and as interoperable as we talk. It is still work in progress. Many bodies have to come together to make it happen, because the code for foot examination is just one, right? And all the entities, the EHR application, the billing system, the doctor's office, everyone needs to kind of identify that this is a particular code that we need to capture, and that's just for one measure for one clinician. Like that, there are many. And then there is one more way, and I think that is the glimmering light of all. And there are CMS certified bodies. They call it as qualified registries, which are QRs, or clinical qualified data registries, which is QCDRs. Okay? So what they have done is that they have authorized these bodies that you can do CMS submission on behalf of a physician. Okay. And these bodies, the beauty of these bodies, these are all third party intermediaries, but the beauty of these bodies is that they are all equipped. They need to perform, these bodies need to get authorized every year. And there are two levels. One is the QR and the QCDR, these third party bodies, right? So I have seen QCDRs losing their QCDR status 1 year uh, because the documentation that they submitted was not enough to authorize for CMS to authorize them to perform this activity. Okay, so there is a lot of audits that happen on these QRs and QCDRs. There are around 85 QCDRs. Sorry, I should say there are 85 QRs and then there are around 40 QCDRs in the nation right now. And all the clinician has to do, the physician has to do is get in touch with them. Okay. And they take care of the documentation. They take care of which codes have to be captured. They take care of submitting data to CMS. Okay. And so I think that is what major thing that CMS is doing to help these physicians stay compliant with these regulations. And then when it comes to QCDRs or QRs, they can submit data for all payers, making it very fair for the physicians. And then there is another way is the CMS can directly calculate based on the Medicare claims that are submitted. But then it will again restrict to Medicare only patients. So there are different ways in how CMS is helping them stay compliant and giving them a helping hand to rise up to the expectations.
Mm-hmm. We love talking
A lot.
about use cases. I know. Well, it's great that there's something like that that is helping these providers because yes, I mean, there's so many question marks around what to do, how to do it, all the different things to know, and like you said, also knowing what is applicable specifically to that provider too. So
Yeah.
you're not getting clouded by other other acts and regulations and rules and knowing your guidelines. We really love talking about use cases and seeing these things in action in the real world. Could you walk us through a use case where CMS submission was successfully implemented and what were some of the challenges and the outcomes of that?
Let's walk through a workflow care style. So at first and foremost is the interaction between the patient and the physician. So it's called as a visit. Even in technical terms, it is called as a visit. So whenever the patient visits a physician, a visit is created. A record is generated. Clinical notes are attached to it. And that record with all clinical notes is sent to the billing center. Then the billing center adds all the diagnosis codes, procedure codes, MIPS codes, because there is a lot of education that goes with if you're tying up with a QR or QCDR. So there is a lot of tie-up between the billing center and the QRs and the QCDRs because then they are the primary source who can enter the MIPS code. MIPS code means, for example, if a foot examination was done or not. Okay. And then this record from the billing center goes to the payers. Correct? An invoice is generated and it goes to the payer. Now there are two ways in which we can tap the information that is required for MIPS processing. One is where the EHR itself is evolved enough to give that output and we can consume that. And the other is from the invoice that is sent to the payers. So for MIPS calculation, we actually don't need how much was the charge and how much was the allowed amount. All we need is the patient details, the physician details, the facility details, the diagnosis code, procedure codes, and the MIPS codes, right? So this information is tapped from the invoice and then there is a standard format in which submissions need to be performed. For example, all the physicians working in a facility can come together and perform one single submission, which is called as a group submission, GPRO. Okay, group practice reporting option is what it is called as. Or one physician working at one facility can do individual submission. And that same physician at a different facility can do another individual submission. And these facilities are also combined together in the form of one tax identification number, TIN, is how it all processes. And then there is a standard format of how this data needs to be submitted, and all they have to do is get it into that format and upload it. The QCDRs or the QRs can do it on the behalf of the physicians as well. So that is one really smooth, simple flow of how a submission is made. There are challenges, but I think QRs and QCDRs are equipped to it. The physician's office, if they are doing it directly, year on year, CMS, they get evolved, and CMS also has a very good helpline available, and they are very prompt in answering the questions. So that is how some of their challenges are resolved.
Yeah, thank you. Thank you for walking us through that. Because and yeah, seeing that in action, it sounds like there's a lot of support and help through that process.
Mhm.
Then, and Sheetal, we have been talking a lot about MIPS today, but what are maybe some of these other payment models within that scope of
Yeah,
value-based care that we've been talking about?
correct. Correct. So there is fee for service model, and then there are alternative payment models. And out of all the alternative payment models, what we focused on was MIPS. And there are other alternative payment models as well available. In fact, to come to answer your question, right? So there are other alternative payment models, and actually the name is alternative payment models that they use. And all different alternative payment models come together to form a value-based care system, delivery system. So one such program is ACO, which is Accountable Care Organization. So what it means is that different providers from different specialties and facilities come together to form a consortium. And you know what? When we were talking about CMS submission, this consortium like is formed by various facilities and all, and this consortium can do one single CMS submission. Okay. So this consortium is responsible for overall well-being of the patient and not just one particular symptom. They can share data across. There is no duplicacy of records. And how it works is that this particular ACO is given a definite amount of budget by CMS to, for taking care of some volume of patients with some percentage of high risk, low risk patients. Okay, so it's like a combination package that they have CMS has given them. And if they spend less than what CMS has provided with quality of care, then the ACO gets to keep the extra money that was allocated to them. But if they spend something more than what was given to them, that financial risk is shared with the payer, which is CMS, and with the providers. So there are different tracks on how this different payment model works. The alternative payment models have more incentives, but they also have more financial risk, as I explained, right? So there are such bundled payment programs for total knee replacement, or there are very specialty specific like oncology care model. So CMS Innovation Center keeps on coming up with this different models of paying the physicians, giving them more incentives for more better quality of care that they provide. But in terms of everything, ACO is the one that stands out. In fact, CMS has published a mandate that by 2030, all the Medicare patients that are seen should be via an accountable care organization. So that is how successful the ACO program is. There are many other programs, ACO Reach. They tweak different programs and try what works, what does not work, what is accepted, what is not. Um, but yes, there are different payment models that can be provided to the providers.
Thank you. Yeah, thank you for that.
Mhm.
We we hear a lot about generative AI. It's here. It's here to stay. It's it's something we talk about a lot in the ecosystem of healthcare technology and healthcare delivery. And it is. It's I mean it's transforming the healthcare industry so far, as well as other industries too, of course. Does it also have a role to play in CMS compliance or the reporting workflows?
Yes. Yes, definitely yes. Every stakeholder in this value-based chain, which is the patient, including the patient, I should say, the patient, the providers, the payers, and the quality payment program team. We also call it as VBC team, value based care team, who is going to actually do the submissions. There are different workflows within AI that can help and leverage or ease out their load. Okay, so AI can summarize and identify patterns in data. In there is natural language processing. Humans can conversationally interact with this AI system. AI agents can be deployed to take care of repetitive workflows and something that doesn't need a lot of human intervention. Obviously, everything should be human in the loop right now, but then there are also generative AI capabilities for predicting, for finding patterns and suggesting ways in which things could be done better. Yes, definitely there is a lot of scope that generative AI and even traditional AI and now agentic AI can help ease out the workflows.
And we have been talking so much earlier about the heaviness of the workflows and all the checks and the
Yeah.
balances and everything. And so something like that is a wonderful tool to have in a physician's toolbox, of course. And I can confirm that yes, the resources that Citius Tech has with papers is a wonderful resource and a great thing to look at it for more information.
Mhm.
And Sheetal, as we begin to wrap up our conversation today, when we look ahead, what should healthcare organizations be preparing for? Are there any trends or shifts on the horizon that we should be watching for?
Yeah. See, as we spoke, value based care itself seemed that this is really advanced, right? But if you are looking at the overall roadmap, let me explain you the roadmap, right? So, value based care models started in 2017. Actually, that is when it became a federal mandate. There were programs even before that which kind of ramped up to what started, like what MIPS had to offer. Okay, there were other programs that merged to form MIPS, and that is there. Okay, uh, ACO programs are there. We are still evolving. So currently, we are just in the transition phase of getting onto this and making value-based care as a normal. Even currently, there are fee-for-service payments that are going on, and I will not, I don't have a number handy to state on a public forum, but yeah. So fee for service is also there, but what we are currently is in the transition phase. Going ahead, we will be in the acceleration phase where we see rapid transition to alternative payment models once once the system gets easier for physicians to do it. Okay? The data exchange format FHIR that we spoke about is going to catch up. The quality measures that we said that QRs and QCDRs are doing it. Okay? So these will become more digital, and FHIR and the electronic health record, the application at the point of care, is going to help make it all digitized. So HHS, which is Health and Human Services, has not yet published the roadmap beyond 2030. But I think that 2032 and beyond will be more of an optimization phase where various healthcare information networks will share information with each other. Even now, it is happening. Um, the initiative is called as STEPCA, where different health information networks, like state-based information networks, can exchange data with each other to make one record of one patient nationally available. Okay, so that is the ultimate goal, and everything is going towards that direction, making it digitalized, value-based care, alternative payment programs, patient-centered experience is something that we should not forget. So that is where it is all heading towards.
And to close, what advice would you give to physicians or organizations that are navigating CMS regulations today?
Yeah. So definitely CMS regulations are here to stay. They are going to become stringent day by day, year by year. Different payment models are going to come in. And value-based care is the future. CMS acts like a catalyst to enable all the physicians to equip themselves, giving them a ramp to slowly move towards value-based care. Okay. Having said that, take advantage of qualified registries and QCDRs, which is one level up. They can do, they have additional measures, specialty specific measures. Okay. So take advantage of this CMS authorized bodies who can collect, aggregate, process data and do your MIPS submissions. They can streamline reporting, they can give you real-time analysis, they can give you predictive analysis. Like if I continue to behave if I continue to perform on my patients as I'm doing today, what will it translate a year later in terms of submissions? Will I get incentives? Will I get penalties? So these third-party intermediaries can help you give that outlook. So, so that is one piece of glimmering hope and advice I would give to the providers.
It's very good advice. Thank you so
Yeah.
much. And thank you so much, Sheetal, for sharing your insights. Your passion for this topic is clear. And it's also clear that while CMS regulations are essential for driving quality, which is very important, of course, they also
Yes.
require some thoughtful strategy and adaptation. And so
Correct.
um, yeah. So thank you again so much for sitting down with us today and for your insights.
It's a pleasure. It's a pleasure, Laurel. Thank you.
The Shaping Healthcare podcast is brought to you by CitiusTech, a leader in healthcare consulting and IT services. To find out more about CitiusTech, visit citiustech.com. To listen to more interesting insights on healthcare technology and innovations, search and subscribe to the Shaping Healthcare podcast. Thank you for listening. If you want to share any feedback or would like to be featured in our podcast, do write to us at citiusvision@citiustech.com.